Thank you for that beautiful introduction. This is a remarkable story. I was working with Eugene Moore on another issue, and he mentioned that his wife had Alzheimer's disease. And I say, "Oh, do I have an idea for you?" And I pointed out that Mohan Dos had written a paper on the use of low-dose radiation to treat neurodegenerative diseases. Of course, this was on mice, and still, he worked very hard, Eugene. He's here. He's trying to find my wife. That's another story. But Eugene tried to find a way how to give his wife low-dose radiation treatment. He wasn't even sure how much he could give her. Mohan recommended 40 rad, and he couldn't get it normal ways, that kind of treatment. So the idea he hit upon finally was CT scans. And so this is a story about CT scans. So I have three co-authors. Eugene, who's the husband of the patient. Victor Hosfeld, he does the radiology at the hospital, where he's the fellow that gave us the dose values after the treatment, because you ask them how much radiation they got, nobody knows. But they have good records, they have good QA, they know exactly the dose that they give each patient for any radiation treatment, and especially CT scans. So he was a fellow that actually helped a lot of this happen. And David Nadolsky is the family doctor of the patient. He's an internist, and the husband came several times and asked for this treatment, and he was a bit nervous, and then he says, "Well, she's got AD. If we image her brain, that can't be such a bad thing. No one will cause me any issues with that." The problem started to come when he asked for repeated. But that's another story. So he's the third doctor, the third co-author. So I'm going to say a few words about Alzheimer's disease. As you know, it's a disease of older adults. It's the cause of more than 50% of dementia. Nobody understands the disease that well, the cause and the pathological mechanisms. Earliest manifestation, well, I guess you can read a lot of that. I don't have to read it really, but it's a leading source of morbidity and death. A lot of Americans are affected. It's very expensive when you look at patient care. That's not all Alzheimer's, that's all patient care, but Alzheimer's takes a chunk of that. Treatments that exist for AD can relieve some symptoms, but there's no cure or really modifying treatment. And I've never heard of anybody who recovers from AD. It progresses inevitably to death. Now, the survival is 3 to 20, usually 8 to 10. And young patients, it's very unusual for them to get it. It's a genetic issue, but when they do get it, it progresses much quicker than with old people. It goes up with age, the prevalence. It doubles every 5 years in old age, and it's second to heart failure as a cause of mortality over that age. And you don't really die from AD, you die from the other diseases that result from AD. And often it's infections, but patients stop eating, they don't look after themselves, and so other causes are the ones that result in death. So first you see memory impairment, and then executive dysfunction. This is an inability to make decisions, an inability to lead. And then there's all these problems. Then there's language and behavior. He's now trying to teach his wife to speak again. So that's even though she understands what he's saying, she can't speak. It's difficult for her, but sometimes she'll say a few words. And then there's the motor tasks of even eating. They'll sit like a vegetable and they won't eat. Well, and that's when it gets really advanced. So everyone says, oh, it's plaque, it's amyloid beta protein. There's markers to measure the amount of plaque. There's a lot of clinical trials underway to look at anti-amyloid treatments. But AD doesn't occur in every amyloid patient. There are a lot of autopsies that are carried out. You see the plaque, but these patients never had AD. So you can't really link, well, you can link it, but it's not supported by evidence that everyone who has plaque has AD. So they do use a lot of brain imaging, CT and MRI, to evaluate AD. And these imaging can suggest alternative, if you think it's AD, there may be other diagnoses you can determine from these examinations. So this disease begins early before you even have symptoms, and then, well, if you could treat it really early, as soon as you detect it, it would be the optimum treatment if you had a disease-modifying therapy. Let's see, did I cover that? Yeah, I guess I did. So let's talk about the case report. She had advanced AD. 81 years old, symptoms began 10 years earlier. She's been getting examinations by psychotherapists who measure the characteristics of the disease, and they noticed that the disease progressed gradually, and she was in the final stages of AD. And April last year, April the 8th, she was admitted to hospice. Now that means when people go to hospice, it's less than 6 months, and they're meant to die. They're expected to die. Well, she was examined by a psycho specialist, and he wrote in their report that she was completely non-responsive. She refused medications, didn't communicate. She didn't even try to get out of her wheelchair in months. Now the spouse, Eugene, and I, we've been corresponding a year earlier. He's been following some of the work and the papers I've been publishing, and he knew that low doses of X-ray stimulate patients' protection systems. And so he was after me. Actually, I was the one who pointed out to him that this treatment might work. And so he was trying different ways. Finally, he hit on the idea of asking the family doctor, her doctor, to prescribe a CT scan. And the idea was to see anatomical changes in the brain, and the underlying reason was to stimulate neuroprotection. That was the real reason. In fact, after he did the scan, no one even looked at it. So this is April, this is July. She got 2 scans. This is an interesting story. He was supposed to get 1 scan, but the image came out blurry. So we gave another scan to get a better image. So she ended up with a double dose the first time at July 23rd. And that was 4 centigrade each, 8 total. And 2 days later, the caregiver in the hospice noticed a big improvement. She wanted to get up and walk. And she started to talk, words here, there, and she started to feed herself. And that's quite remarkable. You get the treatment, and 2 days later, things are changing. It's just hard to believe. So he waited 2 weeks, and August the 6th, and 1 more scan. He had to go back to the physician, get another script. He told him what the results were, and so he wrote another script. And the hospital was accommodating. And then, right after that, there was a further improvement. That was August the 11th. They noticed she was very interactive, talking, reading words in books, asking questions. She asked who people are. Some of them she knew, but she tried to stand up, which was interesting. And she started to eat. And she ate all the food that she was served, which is very unusual. So that's after 2 scans. Then August 20th, another scan. Big improvement, a lot of memory returns. She lifts her legs, turns her head. She was in an exercise class, and they were giving instructions to the patients, the way they do exercise, lift up this arm, turn your head. And she was following, just with the other patients, the same instructions. So she had definitely understood what was being said. And then October the 1st, one more scan. And this is when things got surprising. There's a major setback. And Eugene was totally depressed. He thought, my God, I've done it. She's finished. We're back. And then he said she lost almost the entire improvement that she had from the time she went in the hospice. She said lost 80% of the improvement. And I said, wait a minute. She's resilient. Just wait and let things recover. And sure enough, after weeks, it started to come back. And in November 20th, she'd already made a significant improvement from October. And the hospice decided she's not suitable for hospice. She's got to go. People in a hospice are supposed to die. And they needed the bed for more patients, and she wasn't dying. She was improving. So she was discharged to a daycare program. So this is the results of that treatment that she had. Now, I was there. I didn't believe what he was telling me, so I had to go. And so this is in the healthcare place. And so there's the husband who's here. And that's the patient, Barbara Moore. And what's interesting is she's looking at us. She knows we're taking her picture. And she's eating. She's holding the food in her hand, and she has an appetite. This is not an advanced AD patient. So there's evidence that she really is significantly better. Nobody's ever told me, or I haven't read of any patient in advanced AD that's made a recovery like that. So, explanation. Well, it looks to me like hormesis, radiation hormesis, 3 treatments of X-rays, stimulated adaptive neuroprotection systems. And each time you do it, the body adapts. And so it reversed some of the brain deterioration that was caused by the aging. The optimal dose appears to be the first 2 plus 2 more, 4 CT scans. Those 16 centigrade, 16 rad. The 4th treatment, that's the one in October 1st, inhibited the stimulation and caused a setback. Now that she's recovered, one thing we need to consider is maybe we can do booster scans after 6 months. And in fact, Eugene told me that his wife received, he's a bit impatient. So at the end of March, he gave her another treatment, so it's about 3 weeks ago. And she's getting better and better, and he's thinking about putting her into speech therapy, so that while he talks with her, she's not talking back, and he thinks that maybe she might be able to get treatment that would help her. So what Dr. Sakamoto used to do with cancer treatment of patients was to give a booster treatment after 6 months. So this is radiation dose response model. I guess you've all seen that. And there's the NOEL, where there's no observed adverse effect level, and we didn't go past that, but we did pass the optimum. with this CT scan treatment. So now people say, well, it's just an anecdote case. What's the big deal? And I say, well, although there was only one patient, there were 4 treatments. And within days, you give the stimulus, and you get the change right away. Just days after. You don't have to wait 6 months, or you don't have to do long. You see immediate improvement. So there were 3 improvements and 1 setback. Now, even the setback is evidence that the treatment is doing something. It's not a random sort of thing. And after that setback, she did get a slow, continuous recovery from that into February. That's when I started to make these slides. And he's telling me that she's getting better and better. So my point of view is it's not over. He has to look at a booster course of treatment at some point. So let's look at the conclusions or discussion. Did the CT scan really reverse AD? Do the symptoms of AD disappear naturally? To my knowledge, that doesn't happen. So I believe it conforms to the dose-response model, a benefit, low-dose benefit, high-dose harm. And so this case supports the hormesis concept. And it upregulates protection of the brain against deterioration. There's an optimum dose. Now we can argue different patients, they may have different optimums. Seems like we were very lucky because there are patents out there that suggest 100 times higher dose. I'm not sure how that would work. The radiation was designed in these studies to remove amyloid, not to treat Alzheimer's. So you really need to work with humans. Maybe you can see things in mice too if they go through a labyrinth differently, but when you do studies on radiation effects, the best subject is a human. And so the thing that we need to remember is CT scans are an accepted medical procedure, so there really is no risk. And the likelihood of a benefit, well, it seems that there will be one. Question of finding the right dose. Certainly start with the same treatments. Now, I know today that the CT profession, the CT scanning, they're making continual improvements. Everybody's emphasizing minimizing dose. So the question arises is if you get another CT scan, will you get the same dose or will it be much less? It seems to me you want to be in that dose ballpark, and if a physician looks at that and says, geez, you're giving too much radiation, we can minimize it, we can make it lower. Well, actually you want more, you want that amount. So you have to look at how much radiation is getting in these CT scans. Now, there's many other ways probably of treating this, but CT scans seem to be the socially acceptable, medically acceptable, ethically acceptable way of doing it. So, yes. Well, I got recommendations. Since there's no other treatment, we should do the same scan on all AD patients because, in my view, there's no risk and there might be benefit. You really need to do a randomized clinical trial with controls. Controls would get a simulated scan, and the others would get the actual radiation scan. You need to determine the optimum protocol because we just hit on it lucky. Just got lucky on that. And the other recommendations is if you suspect AD, you should treat it. It could delay the onset of AD. It's prophylactic. You could look at booster treatments. And the other idea this brings up is, since it's neurodegenerative disease, there's other ones. There's Parkinson and Huntington, and so we should be looking at possibility of treating those. So the potential benefits are enormous. The costs are very low. And I guess, yes, we can go to questions. Oh, let me hit on this one. One more slide. Beneficial effects of low-dose radiation. Medical practitioners, they've been using this for over 100 years. But in the last, for over 60 years, they were using it to eliminate metastases, healing wounds, infections, arthritis, lymph glands, pneumonia, and recently Ed did a paper on treating and curing asthma with low-dose radiation in the chest. And all of these studies, there's no mention of increased cancer incidence. So this follows the same. Now we just add to the list Alzheimer's disease. Now the best, everyone's raising a scare about cancer. They're saying that the radiation scare is that cancer increases the risk with more dose. It's the ideal anti-nuclear scare. It's very complex, many causes, confounding factors, uncertain. It's really hard to show, so everybody's just fearful of the possibility, but there's no real demonstration at low doses. In fact, there's demonstration of opposite effects. But the best measure is longevity, if you want to look at what are the health effects of radiation. And there's been a number of studies that have shown that radiation stimulates adaptive protection, increases lifespan, somewhere between 10 and 30% for a median, and the weaker ones get stimulated more than the stronger ones. And that's it. Okay, open up for questions. Yes?
So a couple of things. Some of the most recent findings just a couple of weeks ago from the Society for Brain Mapping and Therapeutics suggested it's not necessarily that it's the amyloid plaquing that creates the problem, but that may be artifactual. So some change in synaptic efficiency. And of course, there have been previous studies that have demonstrated that synaptic efficiency can be maintained and in some cases been optimized through a variety of different stimulatory techniques, magnetic energy, EMPs, and perhaps radiation. That's something I'm paying for. So you may be onto something, just as when they were first doing magnetic resonance scanning, they determined that magnetic pulsing was in fact stimulatory for a variety of brain mechanisms. Point number one. So I think certainly that reinforces the need for a little bit more detailed, if not clinical trials, and investigator-initiated research. The second thing is the dosimetry of this is interesting because you're using such a low dose. And the other question is, are you looking at focal dosimetry anywhere in the brain, or is the whole brain dosimetric sort of bad? The reason I ask that is depending on whether or not the radiation may concentrate in cell bodies versus processes, may provide you with a very, very different effect. And that may also be very important to determining how you may want to use this type of röntgenographic energy to be able to then target what key sites may be. Has that been considered at all?
No, this is very, very simple. You ask the technician, the specialist, how much radiation is that machine delivering, and that's basically energy joules per kilogram, and that's great. And when they measure 4 milligray or 4 centigrade, then that's the dose that's given to the brain, the whole brain. And so you just repeat that same dose. It could be a very interesting study to try and figure out what's happening in detail, how much radiation is going and what to every area, but I think there's no absorption going on there. I think it's pretty well getting a uniform X-ray dose. It goes around this machine, and so it's exposing from all sides, so I think it's a fairly uniform dose over the brain.
Well, two things then. One, that may be required, and number two, that may not be required. In other words, you may be getting an artifact of delivering a particular radiation pulse to a key area that may be very important. So, again, the idea that getting an effect is good, and then trying to create a little bit more granularity and specificity, the effect may be better. The other question I had is, the endpoints, the metrics that are being used, things like eating, being able to have some type of cognitive awareness. Have they been also doing any type of neurocognitive testing on her at all to demonstrate
Yes.
functional improvement?
Well, you answer that. What testing have been done?
Well, we had Barb examined by a neuropsychologist like 6 months ago, and then again like 4 months ago, and just last Friday. And he was tremendously impressed by the difference between 6 months ago and now. The cognitive recognition, the fact that she almost always seems to understand what we're speaking to her, you know, and this is coming from rock bottom. She almost always understands. She doesn't always answer in complete sentences. However, she acknowledges when you complete her sentences.
Yeah, she nods.
Has anyone suggested any form of imaging? I mean, obviously you're doing CT scans, but in terms of actually looking at integrity of brain networks, like a DTI, DKI, any kind of fMR?
Not yet. We're just happy to get the treatment.
Yeah, Jerry, I think this story has a potential of going viral. If it goes viral, how many cases do we have a year of AD? It was 1.5 million, something like that?
Yeah, lots of cases.
Have you thought about that? And if you'd like to see it go viral, which I strongly suspect,
Yes.
what would be your strategy to do that?
Well, I put it on internet, I put it on Facebook, and we've got it in the journal, we've got the link. It looks very professional, it's peer-reviewed. It's very difficult to debunk it. We've specified in the paper what the limitations are, and we also specified recommendations that they do a proper trial, proper clinical trial, randomized with controls, the proper way it should be done. And that's the recommendation. But in the meantime, if people are having AD, there's really no risk in getting a CT scan. I
See, what you need now is another 5 or 10 people.
The study will take many years.
Yeah.
But you got to treat people now, today. In
Yeah.
fact, there is a patient that Ed knows about living in Amherst who's already had one scan, and they've already documented improvement. And not only was it the spouse that was writing the diary, she got the accompaniment. This fellow was in a musical combo, and the person he plays with wrote a paragraph, 2 paragraphs on the improvement in the patient's musical performance over what had been before. You can never finish a piece, a composition. He started it, and somewhere it got garbled. And after the treatment, this is a couple of days, he was able to finish the piece, and they were starting to improvise. So that's happening here in Amherst. So there's a lot of millions of patients out there, and we really should start to do it. But there's people out there like David Brenner who's saying we've got to minimize the dose, we've got to balance the risk, don't give a scan unless you're 100% sure it's necessary, because you could be increasing the risk of cancer. And that's the problem we're fighting. And hopefully this paper will debunk the idea that CT scans are harmful. They're actually beneficial. So that's my answer to that question. I think.
Yeah, this idea has been proposed in 1990s by Kojima to use low-dose radiation to treat neurodegenerative diseases. He is studying mouse model, but for the LNT model, because Alzheimer's disease does not have any solution, people would have tried. I asked him in an email why he hasn't tested it on humans. He said, well, with the LNT we cannot really test it. So because of the LNT model, we have not been able to study this. And I mean, the indications are that it's worked at least in one case, and I think indications are that it would work, and we have actually caused so much harm by not studying it decades ago. So I think that's another reason to get rid of LNT model so we can do these studies without any concerns and proceed further.
How did the research in Japan go with the animal model for this neurodegenerative disease? Can you comment on that?
No, in Kojima's study, he looked at the damage to brain with the MPTP, that's a neurotoxin,
Oh, okay.
with by giving low dose radiation before and then applying neurotoxin. But there's been a recent study where they have done a mouse study with I think about 10 or 15 centigrade radiation dose in a mouse model where they were shown it has better learning capacity with the low dose radiation compared to before. So it's a model of Alzheimer's disease, and they have shown more neurogeneration, more nerves being generated following low dose radiation. So there is evidence for success of this treatment, but obviously you need clinical trials to validate it and use it.
Go right ahead.
Quick question. So I think this is a fascinating story. It's personal. It's got a lot of really high points. I agree that to really get this as a therapeutic option that's well established is several years down the road that would require randomized study, and I think that some of what you've outlined would be a good way to approach that. However, I do think that you don't want to lose any momentum, and that sometimes a series of case reports can do much to improve kind of the awareness of this sort of thing. What I am concerned about, as I was thinking about, well, maybe I could talk with some of the Alzheimer's specialists in my hospital and see, show them the paper and see if there would be anybody that would be interested in this to get a couple of extra patients. I'm immediately drawn to the fact that there has to be an indication written, and the first CT scan wouldn't be that difficult. I mean, I could write the first CT scan, right, in order for that. But getting paid for or getting the radiologist paid or getting the technicians paid for the subsequent CT scans, I would imagine through either some kind of, and we're really fortunate to have a family member here so that we can talk about this. Do you know what the indications were of what your family medicine doctor was doing? Did he run into problems with the insurance company where they say, you just got a CT scan 2 weeks ago?
This is a good story.
You know?
Listen.
I was a believer in hormesis for at least a year regarding my wife's Alzheimer's. And for over 6 months, I had the full attention of the radiation physicist at the Midland Hospital, and we were trying to convince the easiest target, the most progressive, if you will, radiation oncologist to do it. And we went back and forth for over 6 months, and he was ready to do it, but I had to show him someplace else where it had been done. And it hadn't been done anywhere else. So I approached my wife's physician several times with, could he prescribe a series of CAT scans? And well, he couldn't quite bring himself to do it, but on the third approach, I said, I'll self-pay. And that got him out of the insurance loop. And he said, how many do you want? And I said,
Money talks.
and I said, well, I'd like one a week for maybe a year. I didn't know what level was going to be effective. And he looked at me and he said, well, how about 5? And just a minute, let me finish. How about 5? And the big question is, now watch for results,
Wait, how did you pay for it? That's the story.
Oh, well, I said I'd private pay.
Yeah, and
Well,
how much did you pay?
and somehow it turned out that the cost for the analysis, the book price was $1,500. And I noticed that when I was going in and the insurance was paying for prior CAT scans, that they actually received 200. And of that, the insurance company paid 150 and I paid 50. when I said self-pay, the bills, I thought I was going to get billed for the whole shot. It turns out that because I had insurance, that it came back with me paying like $20 instead of $50. And I don't understand why, but on bill after bill after bill, that's what it was. And you tell me.
Okay, that's a piece of important.
Let's see again, was there a question?
So, this is certainly provocative, but there are some indemnity issues and liability issues that go along with this that I think is probably why you're getting some pushback on the part of the physician. And you're probably also going to get some pushback on the part of hospitals. So I think one of the things that needs to be done is probably a stronger and more directed effort, perhaps on the part of this group, to demonstrate, and this language has been used before in literature, that a potential therapeutic option has perhaps been overlooked. Be able to build the case, be able to build the case dialectically, and then advance it in one of two directions simultaneously. First is that I think there needs to actually be a program of IIR, where there are participatory physicians who say, yes, I'm willing to take this on as investigator-initiated research. One of the tripping hazards that exists in IIR are things like liability, indemnity, and providence. And so whenever you utilize a device like this in a way that is off-label and or off-target, it would have to be cleared in some way for that type of use. Otherwise, the hospital may then be liable, or wherever the clinic is. That's going to require at least some interface with either the hospital regulatory board and or in some cases, the filing of an IDE or an HDE with the FDA. It's a little unusual because this is an assessment device, and what you're looking to do is an honest and assessment device to therapeutic ends. It's not impossible to do. It may be given a waiver. But I think absent that, what ends up happening is it's a lot of wheel spinning. What will end up happening is that the other shoe will drop, and the entirety of this overall effort may be squelched. I would hate to see that happen. So I think one of the things that can very nicely develop from the fact that the paper was published in a peer-reviewed journal, does rely on additional literature, is that at this point, one of the things you may want to do is then go back and require something like a right of reference, where you're now saying, well, have other instances of CT or similar type of röntgenographic assessment approaches been utilized therapeutically towards these ends? If yes, what are they? It's sort of a larger and deeper, more finely grained analysis of the existing literature, conclusive from the company that produces the devices because they're liable as well. And at that point, perhaps this is an organization that could literally then mount an effort to say, this is an area that needs to be studied further and needs to be studied not necessarily from the format of a rigorous clinical trial per se, that may actually take years, but in an IIR type format. And in the IIR type format, you may or may not need to file an IDE or HDE based upon the actual parameters of that. And I think that requires some stone turning. But I would certainly advocate that to you, because the last thing you want to do is get halfway down the road and then get broadsided. You get broadsided in such a way that now doors are closed to you perpetually.
But the CT scans are an accepted medical procedure.
No, I
It's the application that's novel.
I understand that, but like so many other accepted medical procedures, one of the problems we face is an administrative problem where the gradient goes uphill. So what they're saying is the off-label use of an accepted medical procedure incurs liability problems for not only the clinician who's doing it, but also the institution which is done. So what you don't want to do is you don't want to turn over what I would consider to be the rock of benefit, only to have it fall on your foot and then become a boulder of burden. And I've seen that happen more than once. So I think what you've done here is you turn over a really, really beautiful stone that then may require a bit of effort to sort of push this stone uphill, not in a Sisyphean way, but I think in a very, very positive way, so it doesn't come rolling back on you.
I forgot one key point in talking to the physician. And this is kind of the sham, if you will. There was some new software developed that allowed you to make very precise comparison from CAT scan 1 to CAT scan 2 to CAT scan 4, 3, 4, 5. And the prescribing physician bought into that. And Jerry may have mentioned that, but you can take CAT scans to follow the course of the disease by comparing precise similar views of the brain. And I think that gets him off the hook.
Not quite.
No, it actually doesn't.
It doesn't, because
Okay. Well,
there was a
he thought
meeting,
it did. Okay.
there was a meeting that said you can't use CT scans for advanced AD patients. There was a consensus meeting, and that kind of, that's a barrier you have to overcome.
I hate to say this, but it's 1:25, and I think that this could actually be the whole afternoon. But I think we actually have to respect the program and people's flights and everything else. And I'd like to thank Jerry and Dr. Moore and your attentiveness. It was an unusual circumstance. It may never happen again, but I'm sure this will be, if there's one thing you remember from this conference, it's going to be Jerry's talk today.
Yes.
So, and my guess is you probably want Jerry's email, because everybody here knows somebody who's going through something like this. And,
I have a
may-
job, you know.
may not talk.
Yeah.
Thank you all very much. We'll see you downstairs.
I make 20 copies, so whoever wants, this is the,